two beautiful countries in the world, India and Australia. This is eCritCare Podcast about evidence-based critical care medicine, helping you to save lives. Here are thoughts on controversies in critical care. And now, here are your hosts, Dr. Swapnil Pawar from Sydney and Dr. Jose Checo from India.
Welcome to eCritCare Podcast. This is our episode number 106. And today I'm joined by my co-host, Dr. Jose Checo. So welcome, Dr. Checo.
Hi, Swapnil. Good evening.
Good evening. We are here to discuss another episode of ICU Journal Club. And the trial that we are going to discuss today is called as Box trial. And we are discussing only one part of this trial, which is around oxygenation targets in patients with out-of-hospital cardiac arrest. As we all know, sudden cardiac arrest is a leading cause of death worldwide, and data from TTM1 and TTM2 trial suggested that almost 50% mortality in this subgroup of patients. Now, resuscitation attempts are started in this patient group. Approximately 1/3 of the victims will be admitted to ICU with ROSC for mechanical ventilation and circulatory support. Now, most of this patient, the reason for mortality or morbidity is because of hypoxic ischemic brain injury, which occurs due to prolonged downtime where brain does not receive enough oxygen supply. So a lot of the focus in out-of-hospital cardiac arrest research has gone to that first 30 minutes of cardiac arrest where how to resuscitate. And a lot of focus has gone on to how we should perform the CPR, minimize interruption with the chest compressions and interventions like adrenaline and early defibrillation. All those things are important, but at the same time, the interventions that happen in intensive care unit as a part of the post-resuscitation care to prevent secondary brain insults like hypoxia are quite important. So I guess this trial is quite significant from that point of view because it's the first largest randomized controlled trial which tries to address the question, what oxygenation target should we aim in this subgroup of patients? Now, we know from ICU ROCKS trial, which was conducted a few years ago, that in subgroup of patients with out-of-hospital cardiac arrest, restrictive oxygen targets may suggest some benefit. Obviously, the trial was not powered to detect any significant difference with regards to that particular subgroup. So obviously, those findings cannot be taken for granted. And I think that's why this trial is important. Now, during the cardiac arrest, we do resuscitate all patients with 100% FiO2 and try to give maximal supplemental oxygen possible during that period of resuscitation. Having said that, once the patient achieves ROSC, the practices across the globe are quite variable. Some people tend to maintain the saturations up to 94%. Some centers try to go with the PaO2 between 60 to 90 millimeters of mercury. So there is no kind of clear consensus or guideline as to what oxygen targets we should aim for in this subgroup of patients. So, Dr. Checo, can you please walk us through the methodology and the results of this Box trial?
Yes, Swapnil, this trial, the Box trial, was conducted in 2 tertiary centers in Denmark between March 2017 and December 2021. So it took more than 4 years. The study included patients who attained ROSC within 20 minutes, but remained comatose after out-of-hospital cardiac arrest from a presumed cardiac cause. The study excluded patients who suffered cardiac arrest due to a non-cardiac cause if more than 4 hours had elapsed between ROSC to screening, and if the systolic blood pressure remained less than 80 millimeters of mercury despite vasopressor support. It was a 2x2 factorial study which used oxygen and blood pressure targets. So we are going to discuss the paper that addressed oxygen targets following out-of-hospital cardiac arrest in patients who remained comatose. The study was block randomized and stratified by site. As I mentioned, there were 2 sites, 2 tertiary care centers in Denmark. So patients who suffered cardiac arrest out of hospital and remained comatose with a presumed cardiac cause were divided into the restrictive group, in which the target PaO2 level was 68 to 75 millimeters of mercury, while in the liberal group, the target PaO2 was 98 to 105. In both groups of patients, they received sedation as appropriate They were mechanically ventilated according to the best judgment of the clinician. Temperature control down to 36 degrees centigrade was employed for at least 24 hours. After 24 hours, the core temperature was gradually allowed to rise, and the sedation was weaned off to assess their neurological status. The arterial blood gas analysis was performed at regular intervals for 120 hours, which is 5 days after randomization, or until removal of the arterial catheter, whichever came first. The FiO2 was initially set at 30% in the restrictive arm and 60% in the liberal arm, and then adjusted to the target, which was, as I mentioned, 68 to 75 versus 98 to 105. The FiO2 was increased in both groups if the saturation dropped below 93%. As I mentioned, the ventilatory management was left entirely to clinician judgment, apart from the oxygenation targets. How do they calculate the sample size? The primary outcome to calculate sample size was death or severe disability at 90 days. So they assumed a mortality of 28% and calculated a sample size of 732 patients to detect a 10% absolute difference in the primary outcome of death or severe disability at 90 days, giving 80% power and a two-sided alpha of 0.05. Finally, they settled on a figure of 800 patients with 400 in each group. So that was what they planned to do. What did they find? There were 789 patients in the intention to treat analysis, with 394 in the restrictive group and 395 in the liberal group. The baseline characteristics were well matched between the two groups. Shockable rhythm was by far much more common than non-shockable rhythms, 85 in the restrictive arm, 84.5% in the liberal arm. A large number of patients had a witnessed cardiac arrest, 84.5 versus 86%, restrictive versus liberal. Bystander CPR again was performed in the majority of cases, 89.2% in the restrictive and 85.8% in the liberal arm. So this is a pretty good system wherein many patients received CPR at the scene by bystander. The time to ROS was a mean duration of 21 minutes in both the groups. Patients in both groups had similar PF ratios on admission to ICU. Separation of oxygen levels between the two groups was evident within 2 to 4 hours and was maintained for the first 48 hours after return to spontaneous circulation. The mean duration of ventilation was 57 versus 61 in the restrictive versus liberal arms. So this is how they matched at the baseline, pretty well matched in both groups. The primary outcome, as I mentioned, was death or severe disability at 90 days post-randomization. Severe disability was defined as a cerebral performance category score of 3 or 4. 3 or 4 means these patients were dependent for activities of daily living, were in a coma, vegetative, or brain dead. So that's CPC 3 or 4. So how did they match? In the restrictive group, there were 126 out of 394 patients who experienced the primary outcome versus 134 out of 395 in the liberal arm. So 32% versus 33.9% restrictive versus liberal for the primary outcome, and which was, of course, not significant. So the primary outcome, death or severe disability, not different significantly between the restrictive and the liberal arms. Among the secondary outcomes were death at 90 days, which is one of the components of the composite outcome. Mortality was 28.7% versus 31.1%, restrictive versus liberal. Here again, not statistically significant difference. Acute kidney injury requiring renal replacement therapy was one of the other secondary outcomes, 8.6 versus 11.9%. Difference not statistically significant. They also assessed the neurological status using the CPC score at 90 days, the modified Rankin score at 90 days, and the Montreal Cognitive Assessment Score at 90 days. We used all the three methodologies, and none of these methodologies revealed a difference between the two groups, namely the restrictive and the liberal arms. They measured the neuron-specific enolase activity at 48 hours, which again was very similar between the two groups of patients. They also looked at subgroup analysis, which included analysis by age, gender, presence of hypertension, renal impairment, COPD, STEMI, shockable versus unshockable rhythm. And in none of these subgroups could they find a difference between the restrictive oxygenation strategy versus a liberal oxygenation strategy. They also looked at adverse events, which were pre-specified, and there was no difference in these pre-specified adverse events, which included infection, bleeding, and seizures. So none of these were different between the two groups. So the final conclusion was that a restrictive strategy of 68 to 75 millimeters of PaO2 compared to 98 to 105 millimeters of mercury PaO2 in the liberal group in patients who arrested out of hospital due to a presumed cardiac cause did not result in a significant difference in the primary outcome, which is death or severe neurological disability, and none of the other secondary outcomes either, which is death at 90 days, acute kidney injury requiring renal replacement therapy, and the different methodologies of assessing neurological status. None of these differed between the two groups.
Thanks, Dr. Jacos. This is quite important trial and which has tested this hypothesis of liberal versus restrictive oxygen therapy for the first time in a very large scale in patients with out-of-hospital cardiac arrest. However, this trial has got a 2x2 factorial design which covered both interventions in the same trial, which is the blood pressure control and oxygenation target control. But also, they interestingly did another randomized control trial within this trial, which was the device-based fever control. So they used the same population to trial 3 different interventions. And I guess the way they calculated the sample size was quite interesting to me. Obviously, the strength of this trial is it has been conducted in a first world country with a very robust trial methodology and design, and it has got a very good internal validity. So I guess all the tick boxes are there. Having said that, the key limitation is this trial is grossly underpowered. The reason being the aim for absolute reduction in the mortality of 10%, which is almost 30% relative risk reduction in the mortality, which is quite ambitious to aim for to start with. But also they kind of try to compare 2 or 3 different interventions in the same subgroup of population and then trying to achieve that much of significant difference. Was quite ambitious. The second important thing is it was conducted in Denmark and only in the 2 tertiary centers. Now, if you look at some of the baseline data, as you highlighted, the bystander CPR rate was quite significant and total downtime was less than 20 minutes in entire cohort of this population. So which is quite hard to replicate in some of the third world countries, but also even in first world countries, to be honest, getting that kind of number is quite impossible, I must say. So I guess the external validity of this trial is also questionable from that point of view. The baseline data that has been quite interesting is 85% of the population in both groups had a shockable rhythm. That means obviously whether the liberal versus restrictive oxygen therapy might have different outcomes in patients who had non-shockable rhythm, that we obviously can't say because the group was dominated by shockable rhythm. Also, as I mentioned, the total duration of CPR was 21 minutes. We know that hypoxic brain injury happens probably around that 30-minute mark. And obviously, if there is a prolonged downtime, then the risk of hypoxic brain injury is quite significant. And again, we don't know if the cardiac arrest would have been prolonged more than 30, 40 minutes. Will that particular subgroup will benefit from restrictive oxygen targets rather than liberal oxygen therapy? So there are a lot of uncertain things, even within the same cohort of population, based on the trial population that we got here. Coming back to some of the other limitations, one of the things that primary outcome was mortality or discharge. When you are having a composite outcome, that can be quite challenging. Now, the observed mortality in this trial was around 28.7% and 31.1% in restrictive and liberal group, respectively, which is quite low compared to previous trial like TTM1 and TTM2, which had kind of like 50% mortality in shockable and non-shockable rhythm. And probably that reflects the multi-center nature of TTM, where when we include patients from different continents and different settings, the mortality will be quite different compared to some of the countries like Denmark, where you have a very high percentage of bystander CPR and early defibrillation. Although the oxygenation targets were standardized and protocolized, the end of life care or the withdrawal plan was not standardized. And I guess that's probably because of the nature of the two centers in Denmark where the trial was held. There could be potentially consistent practice of how these patients get offered withdrawal of care or palliation. But obviously, those practices might vary in different countries, which will impact overall outcomes, length of stay, and duration of ventilatory hours. This trial predominantly evaluated cardiac arrest due to cardiac causes. So again, we don't know what's the kind of oxygen targets should we aim for in patients who had a non-cardiac causes for their cardiac arrest. And probably another important limitation is the follow-up within this trial was quite limited due to the fact that trial was conducted in the midst of COVID pandemic. Now, the good things about this trial is they did calculate CPC and modified Rankin scale at 90 days, which is probably more relevant outcomes than the mortality. And I guess most of the patients who survived, they did really well with regards to the CPC score and modified Rankin scale, which is quite reassuring. Another important factor that they went with the targeted temperature management of 36 degrees Celsius compared to hypothermia. And again, that's good to see that kind of shift after TTM1 and TTM2 trial. So overall, I guess this trial definitely adds significant body of information to our knowledge about this subgroup of patients. It's very safe to say so that we do not need to change our practices at the moment based on this trial data. So I guess continue to maintain oxygen target within PO2 of 60 to 90 is probably the safe to do so in this cohort of population. These are my thoughts. What are your thoughts, Dr. Chekno?
Yes, I agree with you, Swapna. It's a very important study that has come up with suggestions as to what should be an appropriate oxygenation target in post-cardiac arrest scenario. So the authors of this paper suggest that it doesn't make a difference as to whether you set a target of 68 to 75 versus 98 to 105. As to why you may not get a difference may depend on a lot of factors. One of the considerations is that both the groups, in fact, had what may be considered to be a normal range of oxygenation, 68 to 75 or 98 to 105. So the difference was not really all that much. If you remember the oxygen ICU trial, the Italian trial, in the liberal oxygenation arm, of course, that was not cardiac arrest patients, they were general ICU patients. In the liberal arm, they allowed the PaO2 to rise up to 150 millimeters of mercury. So compared to that, this trial used much more conservative targets. So that could be one of the reasons why they couldn't get a difference. The second point to consider is that the target PaO2 levels were attained after reaching hospital, usually after admission to ICU. We don't have exact details as to how much time elapsed. And the separation in oxygen levels were attained 2 hours after ICU admission. So this may have been much longer since return of spontaneous circulation, for which we do not have precise details. You could argue that this may be waiting for too long, particularly if you believe that damage from reperfusion injury and hypoxia occur fairly early during the resuscitation period. So that is perhaps one of the other drawbacks. But of course, it's easier said than done to target such levels starting from the paramedic level, ambulance level, and carry it on to the hospitals. It may not be easy to carry out in practice. So overall, this study does not really show a difference in terms of a restrictive, which is 68 to 75, compared to a more liberal target of 90 to 105. All you need to do is perhaps ensure that the PO2 levels don't rise much more than 100. It may not really make a difference. And Of course, we need to consider the finding on subgroup analysis in the ICU ROCKS study, which showed a trend towards improved survival in hypoxemic ischemic encephalopathy among patients who had a restrictive strategy. So that is a signal that they had, and that's the reason why they carried on with this trial as well. So, but within the range that they used, obviously, there is no difference in the composite outcome of death or severe neurological deficit at 90 days.
Yeah, that's correct. I was just referring to the other core trials that they performed within that box trial. Even with the device-based temperature control for 36 hours versus 72 hours, there was no difference in overall outcomes. So I guess they try to do too many interventions within the same subgroup of population, and it's really hard to then pinpoint which intervention affected the mortality which way. So I guess that's probably the biggest challenge for me in kind of interpreting these results of this trial. Having said that, we do have ICU MEGA-ROCKS trial, which is currently undergoing its recruitment, which is trying to address the same question of liberal versus restrictive oxygen therapy in 3 subgroup of patients: septic shock, out-of-hospital cardiac arrest, and general ICU patients. So I guess that trial will probably tell us about what's the kind of final kind of answer on this topic, because that trial has got almost 6,000 to 7,000 patients aimed to be recruited within out-of-hospital cardiac arrest arm. That trial hopefully will give us a final answer on this topic. But till then, it's sufficient to say that we don't need to go crazy on driving oxygen targets in the range of CO2 of more than 100, as you mentioned, and just try to be a bit more sensible and manage those targets within that 60 to 70 range. That's the kind of key message from this trial. Thanks, Dr. Jacko. So thanks for your time. We'll be back in fortnight time with another controversy or trial. Till then, goodbye and have a nice time.
Thanks very much, Swapnil. Thanks, everybody, for listening in. We will come back with another episode next time. Thank you.
Thanks for listening to eCritCare Podcast. If you like what you just heard, we hope you'll pass along our web address, www.critcareedu.com.au, to your friends and colleagues. And please leave us a positive review on iTunes. Be sure to check out our archive section on our website for previous podcasts. Check us out on Facebook at Critical Care Education. Join us next time for another edition of eCritCare Podcast.